Hi, welcome. Today we're going to be talking about the second chapter in your book right here, which I hope you got, Health Communication in the 21st Century. First author's last name is Wright. If you haven't picked up a copy yet, please do so. I understand that you can also rent this textbook if you need to, so keep that in mind during the semester. And you can just go straight into chapter 2, because we talked about some of the major themes, I think, of chapter 1 when I introduced you to the class and the syllabus. And today we're going to sort of jump right in and start talking about some of the interpersonal interactions that happen in healthcare settings. Specifically, we're going to be talking about, well, let's see, your chapter's titled Provider-Patient Communication. I think you can reverse it and it can be Patient-Provider Communication too, because it's all about these interactions that patients have with different types of providers. And that's something important, I think, to bring out, which your chapter sort of acknowledges that for most of the conversations that they're having, they're talking about interactions between doctors, a specific type of provider, and patients. But the truth is providers could be anybody who's administering healthcare, phlebotomists, nurse practitioners, physician's assistants, LPNs, RNs, basically anybody who you come in contact with who's helping you get some sort of care. Oh, pharmacists even, for instance. So just keep in mind as we sort of talk about these issues that doctors are sort of a good one to talk about, because I would say that they sort of represent what we think of when we think about the medical establishment. But really, a provider could be anybody. Okay, so why are we even talking about this? What are some of the benefits of good patient-provider communication? Why is it even important to talk about these person-to-person interactions that we have as either a patient or provider back and forth? Well, your book mentions a couple of different benefits of if you can have good patient-provider communication. You could look at that as glass half full, like some problems that could arise if you don't. What are some of them? So one of them is patient satisfaction, right? Patients who feel like that they have good means of communication with their providers, their doctors perhaps, tend to feel more satisfied with the interaction as a whole, which is just an important thing as a consumer, right? Your book talked less about this, but I think it's also important for the employees themselves. Good patient-provider communication results in happier employees too, right? Happier medical providers, which I'd say is a good thing. But what about health-wise? Well, research has suggested that people who have better interactions with their providers also have better adherence to treatment. And think about it, of course it makes sense. If you feel like you're communicating well with somebody, you're more likely to take their recommendations. It means you're understanding their recommendations better. And so it's more likely that you're actually going to get the type of treatment and care that you need. There's also reduced malpractice, which also makes a lot of sense, right? Both because better lines of communication prevents errors that could lead to malpractice, and also some types of frustrations that could happen, misunderstandings, for instance, between doctors and patients, that might end up in a court later on, could be taken care of in, before it gets out of control, okay? So given all the benefits, why is it so difficult in some cases to get really good, seamless doctor-patient communication, patient-provider communication? I'm going to start off by talking about, and I've sort of reorganized this. I'm not going in the exact order that your book does. I've kind of condensed it in a way that's easier for me to digest. But I want to start talking about some of the barriers that are in the medical field that make it difficult for us to sometimes have the best patient-provider communication. Specifically, the socialization of the providers themselves. And again, your chapter focuses a lot on doctors, and I think a really important thing to think about is how, different professions have different cultures, right? Both because maybe the training or the schooling, right, there's its own culture. They have similar language, right? They use similar words. Academia, like where I'm from, has its own culture, different expectations of like what you need to go through to get your degree, and how an academic should conduct themselves, how a professor should conduct themselves, how grad students, et cetera, et cetera. It's like we have our own understanding of this because we all exist in the same culture that maybe an outsider wouldn't understand. It's the same thing with medical professionals, and med school in particular has not traditionally had anything that actually teaches doctors about communication. This is slowly starting to change. Health communication is becoming something that more and more medical programs are starting to integrate as a required component of the curriculum. sometimes maybe when it's a little late in the program, sometimes not. But I think it really speaks to not just like the importance of health communication in general, but also how it's becoming to be recognized among healthcare professionals as being something that's very important. One caveat to that is that some of the studies your book mentions says that the problem is a lot of med students don't think it's very important. You may have met people like this if you've taken other communication classes, not just about health communication, but the idea of taking a communication class to begin with is, well, that's just common sense, right? Why do I need to take a communication class? I already know how to communicate. And that attitude is yet another barrier, I think, to even some of the good work that's being done in trying to make sure that medical professionals don't just get the technical knowledge they need to treat patients, but also the different types of skills that are going to make it so that information can go where it needs to go, right? And there was another, well, maybe I'll save this for the quiz. We'll see. There was actually a comment there about which gender is a little bit more resistant to taking these types of classes. And I don't mean to make it seem like all doctors or all nurses are resistant to this type of thing, but I do want to bring up the fact that it's not just merely a level of offering communication classes to make providers better at this. There's also has to be sort of a cultural shift and a recognition that this is an important part of healthcare positions. Another barrier that I had sort of jotted down as I was reading the chapter is stereotypes. And this isn't just a problem with medical professionals, right? It's a problem with really any aspect of society. But we do stereotype different groups of people, and this is the type of thing that could become a barrier in different healthcare settings. Your book at the end of the chapter mentions stereotypes against older adults. We don't say elderly, by the way, we say older adults. And the stereotypes that we hold could affect how we talk to people, maybe using patronizing speech or assuming their level of knowledge about something or their life experiences, when in actuality that's not accurate. And for a doctor, it's particularly important, right, to understand the truth of what's going on and not rely on stereotypes, because so that could be another barrier to effective communication. Jargon. We're going to be talking a lot about a concept of health literacy throughout this semester. The idea that some people have a greater level of literacy about different types of health issues. Sometimes it can come down to understanding different medical terms or names for diseases or treatments or even levels of measurement, being able to read a prescription, right, and understand how that goes. Doctors might assume that everybody possesses that knowledge because to them it's second nature, but obviously that's not always the case, and it's something that healthcare professionals need to be cognizant about. I also put down managed care demands, which was mentioned, and we'll be talking about that in greater detail in another chapter, which is that sometimes doctors have a lot of pressure on them to see a certain number of patients in order to make sure that their practice can stay afloat, or different things. Nurses also have different time demands and how many patients that they have to deal with, and the problem is that sometimes outside of themselves there can be circumstances that make it so they can't spend as much time as they want with patients, and patients might perceive that as them not having a good bedside manner or something like that. So again, there's institutional factors that sort of filter into this too. But I do think it's important to note that patients are not off the hook, right? There's a lot of problems caused with patient-provider communication because of how patients are socialized. We see a lot of medical dramas on television right now. Grey's Anatomy. Actually, I don't even know if that's still on. I gotta be honest, I really hate Grey's. I'm not into like the drama. This, I like a good HBO drama, but you know, sorry, Grey's fans. But before that it was ER, which I've actually heard was fairly accurate. But with varying levels of accuracy about what actually happens, you know, and how what happens in these drama compares to real life, right? The problem is that for some people this might be their only experience with different types of medical settings, and they might get all of their ideas about what a patient-provider communication situation is supposed to look like. And if it doesn't live up to that, then they feel disappointed, then they feel hurt, then they feel, misunderstood, whatever the case is. And so that could in itself be a barrier. The doctors might be doing everything correctly, but the patients just had a different expectation of what should be going on. On that note, I actually really appreciated there's a discussion about the difference between patient expectations that can be more paternalistic versus consumeristic. And the idea is that some patients are more oriented to looking at medical providers, particularly doctors, in different types of way as far as what are you supposed to do for me? A person who takes a more paternalistic viewpoint looks at the doctor as sort of an all-powerful, all-knowing person. The patient comes in and is there to listen to what the doctor has to say and do whatever the doctor says to do. And if the doctor, leaves you waiting for a little while, well, that's the doctor's call because that's the doctor. Okay, so that's like on the continuum of very, very paternalistic. Somebody who has a more consumeristic point of view is sort of, what have you done for me lately, right? It's the person who, how dare you keep me waiting, and I pay good money for this, or my insurance pays good money for this, or whoever, or no, I am coming to the doctor for a particular service, and I want you to do X, Y, and Z, and whatever, and could you prescribe me this drug that I saw on television, please? Certainly, I don't think anybody's necessarily, well, maybe some people are, but usually people might fall somewhere in the middle of the continuum there. But the idea is, again, getting back to this issue of patient expectations, that depending on how a patient sees their role and the doctor's role, there could be conflicts if the doctor or some other medical provider doesn't hold the same perspective about how the medical encounter is supposed to go down. So that could be a source of some conflict, right, in a patient-provider situation. Also, going back to this literacy issue, I don't want to hit on it too much because same thing, though. If patients have low levels of medical literacy, and they might not even realize it, but even if they do, they might not feel comfortable speaking up about it and asking for clarification because they feel stupid that they don't know what a CC is. I actually technically don't know what it is either, but it's a unit of measurement. But you get my point, right? If the doctor's sort of talking and it's a natural language to them because that's what they do in their culture, there could be problems if they're talking to somebody who doesn't have the same level of literacy as them. And that also brings up this point of uncertainty. Patients are often uncertain, and there's a lot of factors that contribute to that. Maybe it's because they've been spending a lot of time on the internet and looking at different causes and symptoms, and they're not really sure what's going on, or maybe it's just because they're having some sort of sensation in their body that they're not certain about what's happening, and uncertainty breeds a lot of apprehension when it comes to communication, and this could also make them both less likely to speak up in some cases, but it could also bring some emotions into the communication situation that maybe medical staff aren't completely prepared for, which I'm not saying is a good thing, by the way. So what are the solutions? Well, if it was that easy, right, we wouldn't have a class about it. Well, actually, we probably should. I need to shut my mouth more. So the solutions I think that your book emphasizes the most is what I mentioned before. I don't want to put all the onus on healthcare providers, but I do believe that I think we have the most control to do something about, for instance, what sort of education our providers are getting about these different patient-provider issues, right? And educating them about some of the things we're talking about in this class, which is all the different factors that sort of come in to influence a communication situation so that they both have a better handle on what's going on, and they can also control the factors to the best of their ability, right? And create optimal communication situations. I think it's harder, right, if we want to change patient expectations across the board, especially since they differ anyway. But on that note, patient education is important. And this might even be something that providers seek to do themselves, maybe through doctor's office, or tell patients up front, here's how we run things, et cetera, et cetera. But again, even that's a communication issue, you understand? Even that's something that could be done to improve communication by using communication. And one of the things that it would be emphasized in some of these classes in education is, I would say, more empathetic communication. We do know from a lot of research that patients need to feel validated. Interestingly enough, it's the same type of communication that makes relationships work better. All relationships, marital relationships, boyfriend-girlfriend relationships, parent-child relationships, right? The same sorts of things that you may have learned about in other comm classes or will apply here too. But if providers don't have them, and patients don't really know what to expect, right? All of these things could set up bad situations. The last thing I would just want to end on is a theory to sort of help you understand how people, not necessarily like myself, but other people in the department who study these face-to-face interactions in medical settings, how they actually do their research. And there's a theory, one of the theories that could be used to sort of guide our case studies or more general studies of what's going on in patient-provider communication situations. It's called communication accommodation theory, and you may have learned about this again in other classes like intercultural communication, interpersonal communication, because again it applies across the board. It talks about how we can actually match somebody else in different aspects of our communication. If I'm doing a lot of this with my hands, you might meet me with a lot of hand, flailing. Oh, we would look very funny, right? Maybe it's better I'm not teaching this class in person. You would adapt your communication to me, right? And that creates better outcomes. There's actually three, and there's really four, but I'll talk about three things that your book brings up about different situations that can happen. You can have a convergence. Maybe you adapt how you're talking about an issue to me. So instead of talking to me like you're talking to one of your friends from med school, right, you instead bring down your communication so it's something that your parents could understand as opposed to your friends, right? And that's obviously like an ideal thing that we would want from our providers. Divergence, though, is where the opposite happens, where, again, you might start talking and using all sorts of jargon, or kind of literally speaking a different language. Not literally, but very close to speaking a different language, speaking medical language, for instance, instead of speaking normal people language. And that would obviously be diverging from this accommodation that we're seeking out. But you have to be careful, because sometimes what can also happen is over-accommodation, where because you're trying to match somebody, you can actually be offensive, sounding patronizing, right? If you talk to an older adult, because you're afraid they can't hear you, right? You're sort of over-accommodating based on your assumptions. And so, again, all of these things, this isn't necessarily a theory that's used directly for advice all the time. Sometimes, if we're just trying to figure out why certain things worked well versus why certain things didn't, we might rely on a theory like this. So at least once a week, I'd say I'm going to try to bring in at least one theory so you can, I'm maybe not all the time, but as much as I can, so that you can see how we're applying these theories to understand the different phenomenon we're talking about. And I think that pretty much covers it. So thank you. Don't forget to take your reading quiz. Bye.